Okay, so next up we have Katherine Battle, who's from Pete Gething's group and the MAP project. Thank you.
Thank you. So I think we have a slightly different title than what was on the program, but from MAP, what I was going to talk through is some of the challenges that we faced in trying to map spatio-temporal dynamics of infectious disease, and specifically in the context of malaria. So for those of you in BDI and beyond who are not familiar with MAP, our research group was founded about 10 years ago with the initial goal to try to define the global endemicity of malaria. At that time, the existing evidence base was quite vague and kind of a ballpark estimation of how malaria burden varied throughout the world, with very little geographic sophistication, which made it of little utility in terms of operational and strategic planning use. So the way that we went about trying to improve that was to first assemble a large empirical evidence base, and we gathered as many infection prevalence surveys as we could get our hands on through literature, contacting collaborators, and now we gather more systematically from demographic and health surveys. We also gathered data on routine case reporting from countries so that we could confine the predictions that we were going to make about the geographic burden of malaria to places that we knew would likely have malaria. We developed new analytical techniques, which our group leader Pete led, and this was using Bayesian geostatistics to produce predictions of malaria prevalence, and importantly had associated measures of uncertainty with them. And through these global outputs that we produced, we were able to engage with a number of partners, specifically the WHO's Global Malaria Program, Global Fund, various national malaria control programs. We have operational partners that are based in country, and also a collaboration network within academia, being within NDM and the Oxford Tropical Network, but also partner institutions as well. So this is what our first global products look like. These were maps produced in 2011 on top for Plasmodium falciparum, and 2012 on the bottom for Plasmodium vivax. And the color ramps show a prediction of what the prevalence would be within a 5 by 5 kilometer pixel within the malaria endemic world. So slightly improved from that first map that I showed. Moving on from 2012, we expanded our work to be even more policy oriented and wanted to measure the change in endemicity of Plasmodium falciparum in sub-Saharan Africa in order to evaluate the impact of control. And the reason why there was a need for this is that around the turn of the century, with goals being established such as the Millennium Development Goals, there was a huge, massive investment in malaria control. And malaria was thought to be on the decline, but there was little evidence of exactly how much and what was causing it, which prevented proper advocacy for what control strategies should be further invested in or potentially reevaluated. So how this was done, this is kind of a very broad overview of quite a long, painstaking analysis, but in general, what was done is we took the similar infection prevalence surveys that I mentioned for the global work, fed those through standardization models so that observations from different age groups could be predicted to the same age group, diagnostic standardization, because while microscopy was generally used to diagnose malaria in the past, we now have observations from rapid diagnostic tests or molecular methods such as PCR. Our environmental covariates, which kind of inform the spatial heterogeneity of malaria, are primarily derived from remote sensing satellite images, but unfortunately we can't just use them as are. They require some processing in terms of filling in gaps of where there may have been cloud cover during the satellite observation. We model and derive some of our own bespoke covariates and run that through covariate selection. And finally, because we wanted to know what caused any change over time, we also modeled what the interventions were that were primarily used in sub-Saharan Africa in the last 15 years. And this was insecticide-treated bed nets, indoor residual house spraying, and treatment with artemisinin combination therapy. So once those were modeled, all of those components fed into a full space-time geostatistical model to produce what we call our PFPR, or Africa cube. And we call it a cube because it shows how endemicity varies across space, but then also through time. So we have products such as this map here that show how endemicity varied for every year from 2000 through 2015. And we would also have maps of what the incidence would be so that we could calculate cases, and then those intervention maps that I mentioned for nets and spraying. And from this, we were able to quantify what the relative decline was. So we predicted that there was an approximate 40% decrease in cases in Africa from 2000 to 2015, and that insecticide-treated bed nets was the greatest contribution to that. And it was the most widespread used intervention strategy, and it was responsible for about 68% of the cases averted. Moving on from the Africa-specific work, we have last year and this year expanded that to include the entire malaria endemic world, and we're mapping and predicting change over time for both Plasmodium falciparum and Plasmodium vivax malaria. And the reason why it's useful to have estimates of what we call the burden of disease, which is the number of cases or deaths caused by a disease each year, is that then you can kind of advocate for investment in that disease relative to others. And it also allows for us to, as with the Africa analysis, measure the impact of different control strategies that are used throughout the endemic world. And these results that we produce feed into the global burden of disease study, which people here may be familiar with, that's run out of IHME at University of Washington. And we provide the estimates for the WHO's annual World Malaria Report. So how this was done was a similar framework to what we did in Africa, but as you can see in this tiny map at the bottom here, we have very good coverage of surveys within Africa, which allowed for us to produce those robust models. But outside of Africa, there is a dearth of evidence in terms of cross-sectional prevalence survey. So we had to adapt to use routine case reports, which are more common outside of Africa and can be strong evidence sources. I'm not going to go into this kind of process in detail, but this is our big picture overview of how we produce these global estimates of burden. But I want to focus on the yellow squares, which represent our data inputs. And these are some of our biggest challenges at MAP, which is gathering together all these different types of data from various sources at varying spatial and temporal resolution and making them work together and talk to each other in our different models that we use, which are represented in green, so that we can produce one output. So from our global work that we've been specializing on, we've also gone much more country specific. And so from the last year and moving forward, we've committed to providing country level support for malaria elimination. So as we've seen in Africa transmission declining, many countries have made commitments to eliminate malaria by certain time points. Some countries have goals that are just in the next few years. And every malaria endemic country is constrained by funding and logistics, and there's a need to optimize the resources that they have in order to maximize their input. And we at MAP needed to be able to have the time and space to develop new approaches for how we would model transmission in these low transmission elimination settings, because the methods that we've used globally and in Africa wouldn't apply. And because we're working on a smaller scale, we want to produce high resolution geographic outputs so that we can very finely target our recommendations for what control strategies could be used. This work feeds directly into national control programs through our partnership with the Clinton Health Access Initiative, and connects to networks that we have, such as the Asia-Pacific Malaria Elimination Network. So again, this is not something I'm going to go to in detail, but capture some of the country-level work that we've done. And just to highlight that we have various data input sources, which are at different geographic resolutions, and being point data, we sometimes have aerial observations at different temporal points for different species. And depending on the different factors, we use a different modeling framework each time, and each country requires its own bespoke model to be run. So a snapshot of the type of country-level work that we've produced. So from health facility observations of number of cases, we can produce maps of predicted incidence. So how many cases would we predict to be in each 1 kilometer pixel of that country each year? From individual household observations of where cases are, we can run a point process model to predict incidence. We also predict, using also data from household surveys, what treatment seeking rates would likely be, estimate catchment populations of health facilities, use information on accessibility to those health facilities to determine where best would new health facilities be placed, or community health workers, and again, leveraging some very common data sources of polygon observations of incidents to produce fine-scale maps of pixel-level predictions to help target interventions, and also using serological evidence to improve on these sort of aerial observations to produce fine-scale maps of transmission. So moving forward from here, and why we're very glad to be placed in the Big Data Institute, is we've seen in our recent years a huge expansion in the volume and complexity of the data that we have coming into MAP. Currently, our database covers 100 malaria endemic countries. We have the infection status of about 5 million individuals. We know the intervention coverage in terms of nets or spraying of thousands of households. We have thousands of districts and province case reports. We have observations of the vectors that transmit malaria and insecticide resistance. Our covariate data that informs our models is probably our most data-heavy aspect, because those satellite observations that we have, some of them are for every 8 days for the last 16 years. And our mapped outputs are based on model outputs from thousands of iterations that we then take the mean and report the uncertainty of. So we have billions of predictions stored as well. And the trend that we've seen in gathering our household prevalence surveys is definitely exponential. It's been growing not only because of our increased effort to collect it, but also the malaria research community making more data available. And this is likely to only get increasingly more so as we gather data from molecular diagnostics, include data on genetic sequencing and serology, and mobile phone records in order to measure things like population movement. And our relocation here is integral for this, just for the computational architecture to be able to do this and store the data and run our models, and the expertise for how best to do so. And as we develop new analytics, our questions include how can we measure transmission in these elimination settings where there's very, very few cases, and how can we best stratify what the targeted interventions should be in a way that's feasible for different program settings, and how can we monitor and control things like insecticide resistance. In order to do that, we need to have a better understanding of parasite population structures in order to understand the parasites' movement, mixing, and evolution. So we're well placed here to have MAP co-located with MalariaGen and the Center for Genomics and Global Health here at BDI, so that we can integrate the world's largest research of malaria genomic data with our epidemiological data and our kind of co-analytical techniques. So we're very excited for that. So I'd like to thank the wider MAP group. There's only a subset of us here today. and you'll see us up on level 1, and to thank our collaborators who provide much of this rich data that we have, and our funders.
Thank you. Questions for Katherine? Hi.
I'm not in the Centre for Population First and Non-Communicable Disease Prevention, but my centre is interested in climate change and its effects on food production. Just wondered whether you looked at climate change in your models.
Yeah, so we had done an analysis looking at climate change and how it could potentially be increasing the spread of malaria, but what we found, luckily, is that the control strategies employed are decreasing malaria faster than climate change could expand it.
I'm just going to ask
Yeah.
you then. So I noticed in your plot of how prevalence has changed over the years and the contribution of the different interventions, actually the overall trend, even without the interventions, was downward.
Yeah.
But what's the cause of that?
Well, so there's some interventions that we, didn't cover.
Yeah.
So it would be increased infrastructure and, accessibility to health facilities. So we've seen that as a big predictor. And Lucy, who's here, has done work on just by people improving the quality of their homes, that greatly improves their chance of not getting malaria.
So Tom had raised his.
So some of your products come from a sequence of steps, as you should. I'm just wondering, to what extent does the uncertainty propagate between all those steps?
It certainly does, and so we quantify the uncertainty as you go along. So as you saw, we had our intermediate products, and so uncertainty is kind of brought into the prediction so that we sample from the full range of what the uncertainty would be of the input. But yeah, so it definitely does propagate through, so that's why we feel it's very important to communicate it at each step of our outputs.
So, yes.
Hi, David Monsell, postdoc over in Crystal Fraser. You're creating an incredible infrastructure for studying the geospatial epidemiology of malaria, which is presumably unparalleled. What are the benefits and challenges, do you think, to helping sharing that infrastructure and data to understand other pathogens?
Yeah, so there's definitely great potential for that. And when we were based back at zoology, we started to expand MAP into kind of the spatial ecology and epidemiology group, and we looked at dengue and leishmaniasis and other things. So there's a lot of overlap, and one of our big remits at MAP is to be very open source and collaborative in our data as well as our methods in terms of the models used and the infrastructure that we use to support it.
Okay, I think we'll move on. So let's thank Katherine.
Thank you.